Muscle-invasive bladder cancer has for decades been treated with radical cystectomy, which has a significant negative impact on patients' quality of life. At the Amsterdam University Medical Center, a bladder-sparing treatment based on chemoradiation is now offered to selected bladder cancer patients. In this video, you'll meet some of the pioneers behind this treatment option who share their experiences and considerations. Radiation oncologist Dr. Martin Hulshoff, Professor in Urology Dr. Jeroen van Masselaar, Urologist Dr. Jaco Neuwenhuizen, Medical Physicist Duncan den Boer, Radiation Therapist Jessica van der Hemst, and last but not least, you'll meet Robert, a patient who has received this treatment.
We know from decennia already that bladder sparing treatment with radiation or radiochemotherapy leads to similar results compared to a radical cystectomy. We know that from comparative studies, we know that from the RTUG studies, we know that from the British BC 2001 study, the James study comparing radiation versus radiochemotherapy, and we know that from several systemic reviews comparing radical cystectomy with chemorad. We also know that chemorad leads to less toxicity compared to radical cystectomy, and very important, it preserves the bladder. It preserves the bladder function and it preserves sexual functioning. Given the fact that there's no significant difference in overall survival and local regional control, I really believe that it's the patient's choice whether he prefers radical cystectomy or bladder preserving treatment, and it's of course only possible in selected patients suitable for either treatment. Of course, not all patients are eligible for radical cystectomy and not all patients are good candidates for bladder sparing treatment. Patients with a hydronephrosis, one side or both sides, do more benefit from a radical cystectomy than bladder preserving treatment, because you lose probably your kidney function if you give them chemorad. Multifocal tumors also are more eligible for radical cystectomy than bladder sparing treatment. And also those patients who have a very bad bladder functions, we call them bladder cripples, they probably benefit more from a radical cystectomy than for a bladder sparing treatment, because there's no good function to spare. On the other hand, there are several patients who are not eligible for radical cystectomy, mainly the older patients and those patients not fit for surgery. So there's a really selection necessary for patients in which either radical cystectomy or a bladder sparing treatment is the treatment to be preferred.
Yeah, that's not an easy question. I'm a urologist and I'm used to surgery, of course. And what we can give to our patients is a radical cystectomy. But on the other hand, a bladder sparing technique is also a very good option. As urologists, we do the transurethral resection, so we remove the bladder tumor. And then we ask the patient, what do you want? Do you want to keep your bladder or shall we remove it? And both have advantages and disadvantages. But I think there is a good option for a bladder sparing treatment. Indeed, I believe that bladder sparing treatment can be curative. When you're really comparing the right patients, so the same patient, the same stages, the outcomes might be the same. And it has been investigated in Canada. It was presented as the ASCO GU 2 weeks ago. There they compared the overall survival and cancer-specific survival of radical cystectomy versus TMT, and they were about the same. So indeed, I think that the outcomes can be very good and can also be curative with bladder sparing treatment. It is a very difficult question. What is the better quality of life? And some patients, they're happy that everything is removed, that they don't have a cancer anymore. And there are patients that are very happy that they still have their bladder. So it's difficult to compare. I think you have to explain beforehand to the patient what are the options. And an option of a bladder sparing treatment, I think, is a very good option also when you look at the quality of life. We have to be aware that in bladder sparing treatment there's still a role for urologist. First, of course, we do the TURBT, but then in the follow-up of the patient we have to do regular cystoscopies in the first year every 3 months and then every 6 months. And sometimes the treatment is not effective, and then we still have to do a radical cystectomy. So there is still a role for a urologist in these treatments.
Currently we have the technique for focal bladder irradiation and spare the non-involved bladder. And the technique we use currently, its routine use, is the implantation of fiducials. That's nice for delineation of the primary tumor on your planning CT scan, and very important, we use it for daily positional verification during the irradiation. Furthermore, we use those markers and those focal bladder irradiation for online adaptive planning, meaning that for every fraction we delineate the tumor, we delineate the bladder, we recalculate the planning, and we treat the patient very accurately, knowing for sure that we spare the non-involved bladder, knowing for sure that the primary tumor is in the high dose area. The ideal fiducial for bladder cancer treatment should fulfill the following criteria. It should be very easy to implant them on an outdoor patient clinic based. Every urologist should be able to implant those markers. Furthermore, they should be non-toxic. There should be no toxicity at all from the implantation of the fiducials, not acute toxicity, not late toxicity. Furthermore, they should be stable. They should be stable during the whole treatment. And of course, they should be visible on the CT scan, where we need them for delineation of the target volume. And of course, they should be stable during the whole radiation treatment, where we use them for daily positional verification and daily adaptation of the target volumes. Of course, those fiducials are only needed for those patients who have focal treatment. So we implant those fiducials only around a focal tumor. It's not used for multifocal disease, because in those patients we treat the whole bladder.
I think the main challenges for a fiducial marker in the bladder are to put the marker in the right layer of the bladder. So you have to perforate the mucosa and put it submucosal. And the second main challenge is that you should be able to have it stick over there, so it shouldn't come out into the bladder again. And then there are of course some problems with the location of the bladder tumor, because you preferably have a circle around your bladder tumor. It depends a little bit on where your bladder tumor is. So if your bladder tumor is very near your bladder neck, then it might be a little bit more difficult than when it's, for example, in the bladder dome. I think the main advantages of using a liquid marker instead of solid markers for the bladder wall are several. I think it's quite easy for urologists who are used to put other liquid stuff in the bladder wall, like botulinum toxin, because it a little bit appeals on the way that works. Another advantage is that it's an uninterrupted procedure, so you don't have to reload solid things, so you can do one procedure, and that makes the procedure also fast. And then there's one extra advantage, I guess, is that if you're not sure that there's enough marker into the bladder wall, you can add some extra marker, because you can easily put some extra units or clicks in the bladder wall if you want to do that. and I think it's very easy to be done with a flexible scope. So it can be fast, easy, flexible, and you can add some extra material if you need that.
Right, so we want to use markers to make visible what would otherwise not be visible. So we can really improve our workflow there. Furthermore, it has to stay visible for the entire course of treatment. So it doesn't work if it's only visible for the first few irradiations, but we need to have the entire course. And we also need to be able to have confidence, to trust that they are in the right position and that they stay in the right position. So we bring them in near the tumor, and we have to have faith that the entire treatment, they will stay near the tumor and stay visible. So when we have the markers, we are more certain of what we're doing and where we can get the irradiation. So in case of a tumor, when we put the markers near the tumor, we can also boost that region. And for the bladder, that means we can have a bit less dose at the healthy part of the bladder. Knowing where it is and with more certainty, we can also decrease the margins, which also helps lowering toxicity in the rest. And for the bladder, it's while we're doing the online adaptive procedure that takes a bit of time. So the bladder fills while we're doing this. Just before we start treatment, we check one more time to see where everything is. And with the markers, we can also see where the tumor is and really make sure that that's covered by the dose.
So as an RTT on the treatment machine in adaptive radiotherapy for bladder patients, we check if the influencer structures are delineated correctly, and if not so, we adjust them. And then we also check the position of the GTV, and we use the fiducial markers to make sure that the GTV is delineated properly on the CBCT. And we work in a big collaboration with our physician, and there's always a collaboration between RTT and the physician to make sure if we can treat the patient properly. We use the fiducial markers as a tool to make sure that the position of the GTV is exactly the same as it was on the initial planning CT. So the machine adjusts the position of the GTV, but with the help of the fiducial markers, we make sure that it's exactly in the right position. Fiducial markers help us a lot with adjusting the delineation of the GTV, and it saves a lot of time because sometimes we're not able to see the GTV properly on the CBCT.
Well, I think it's very important, as everyone does, that cystoscopical active surveillance, mostly every 3 months in the first year, is important to detect an early recurrence. Because for those patients with only focal treatment, if a local recurrence occurs, there's still an option of a radical cystectomy, a salvage radical cystectomy. Most recurrences are detected during endoscopy, but during endoscopy you don't see the fiducials anymore. So in that sense, it's not very important for the follow-up, although on a CT scan, also after a year, you still see some effects of the fiducials. So on a CT scan, you can see whether the local recurrence, if it occurs, is at the primary site or outside the primary site, although that doesn't have influence on the salvage treatment itself. So in general, there's no big role for the fiducials for detecting early recurrences. Yeah, I'm convinced that bladder sparing treatment will improve quality of life and will reduce cost, although there's still no hard evidence that it improves quality of life and it will improve the cost for the society. Studies are running on that, but in fact, it's not important whether I think if it improves quality of life, because the most important thing is that the patient thinks that it will improve his quality of life. And if the patient thinks my quality of life is better, preserving my bladder function, preserving my bladder, preserving my body integrity, and preserving my sexual functions, it's up to him if we can prove that survival and local regional control are equivalent between the two. About the costs, there's no evidence in literature that the costs are reduced by bladder sparing treatment, but if you realize the cost of an operation, if you realize the cost of toxicity, knowing that about 20% of the patients after radical cystectomy got readmitted to the hospital for complications, and if you realize that those patients have lifetime the use of a stoma and stoma material, I think that the cost for society will be reduced by a bladder sparing treatment. But that's the question of a running study currently in our institute, and we hope to get the answer in 1 or 2 years. Good afternoon. We see each other back again. Last week you finished your radiation treatment, and I'm thank you very much for coming here again to join with us your experience in the whole procedure of bladder cancer and bladder cancer treatment in your case. Okay. Is it important for you to have that choice between those two completely different treatments?
Well, it would be if I had known about it. I was not aware that this possibility exists. In fact, most doctors I spoke to, they all said the same thing. Now you either have an operation, which is the real good treatment, or you have something else, but then your days are finished. Yeah. So I was very happy that you told me, well, what I'm going to do is put those markers inside so we know exactly what we can attack. The rest of the bladder will remain, and it might even function. I don't know. We have to see. And that was, of course, a big relief.
What would your advice be to another bladder cancer patient if he was in the same situation as you was, focusing on the treatment, the choice between removal of the bladder or bladder sparing treatment?
Go for a treatment that has as a motto, if it ain't broke, don't fix it. Keep that you leave alone what is not what need not be cured. No. You see, that's the most important thing. If you can concentrate your healing energy on just the part that you want to eradicate, well, of course, that's a very good thing. So I would certainly advise that.
No. Thank you very much for this interview and giving your opinion.